Video we will be talking about Helicobacter pylori infection. Specifically, we will discuss how Helicobacter pylori infection can cause duodenal ulcers and how Helicobacter pylori can cause gastric ulcers and cancer risk, stomach cancer risk. So before we go into that, let's review Helicobacter pylori briefly. It's a gram-negative spiral-shaped bacteria with multiple flagella, and that's why with this flagella it becomes motile. If we look at a picture, so here you see a Helicobacter pylori, and in this side here it has multiple flagella, and with that flagella they become motile, and they exclusively colonizes the gastric type epithelium, meaning that you will only find them in the stomach epithelium or stomach mucosa. You will not find them in the respiratory epithelium, let's say. But there are some exceptions when gastric metaplasia happens. For example, in the duodenum, the duodenal epithelium is different than the gastric epithelium, right? So in some scenarios, the duodenal epithelium can be replaced by gastric epithelium, and that is called gastric metaplasia. And when that happens in the duodenum, because now you can find the gastric type epithelium, then Helicobacter pylori can colonize the duodenum, and it adheres to the epithelial surface. So if we look at a picture, here you are looking at a zoomed in a portion of the stomach. So if you remember, from outside to inside, the stomach layers are serosa, muscle layer, submucosa, and mucosa. And if we look at the mucosa, you can see that the mucosal lining or the gastric lining is called gastric epithelium, this layer here, and inside that we have a mucus layer, and inside that of course we have the stomach lumen, which is filled with fluid or the gastric content. So you can see here, these are the Helicobacter pylori. They are adhering to the epithelial surface, and they can create urease, which is an enzyme, and that urease converts urea to ammonia. And if you remember, ammonia it has alkaline property. It can neutralize the acid. So in the stomach there is a lot of secretion of hydrochloric acid from the parietal cells that increases the acidity. Now that acidity is not good for the Helicobacter pylori itself. So to counter that, it uses this method to neutralize the acid and making a comfortable environment surrounding it so that it can colonize that. And also that ammonia can directly damage these gastric epithelial cells. And in addition to that, because this is a pathogen, so body will, like, the immune cells will be recruited here, and they will also contribute to inflammation in this gastric mucosa. So that is what I have mentioned here: urea production that converts urease production that converts urea to ammonia, which neutralizes pH and thereby protect itself from the acid. Now let's talk about the clinical outcomes of Helicobacter pylori infection. In a broader sense, you can get any of these three outcomes. One is the mild pain gastritis, two is antral-predominant gastritis, and another is Corpus-predominant gastritis. So the mild pain gastritis, as the name implies, it's mild, and pain, so it's a diffuse inflammation of the stomach mucosa. And actually that scenario is the most common scenario. So majority of the individuals infected with this Helicobacter pylori will have mild pen gastritis, and most of the patients will remain asymptomatic, meaning that you don't know that until you do endoscopy or biopsy of the gastric mucosa. But this is asymptomatic. But how can Helicobacter pylori infection cause duodenal ulcer or gastric ulcer or gastric cancer? That is the main focus of this video. First, before we go into this, let's talk about what is antrum and what is corpus. So if you remember or recall the anatomy, this is the stomach, right? And this region is called fundus, and this region is called the body of the stomach or corpus, and this region is called the antrum, and this is the pylorus. So in the antral predominant gastritis is when the Helicobacter pylori infection is predominantly here, and in the corpus predominant gastritis is when the Helicobacter pylori infection is predominantly in the corpus or body. So before I talk about the antral-predominant gastritis, let me draw the stomach here. So let's say this is the antrum and this is the body or corpus. So as I mentioned, the antral-predominant gastritis is when the infection is predominantly here. Now again, before we go into that, let's review a little bit of physiology that we need to understand. In the antrum, there are a lot of D cells or delta cells that produce somatostatin, which is a hormone. Somatostatin. And in the antrum as well as in the body, there are G cells which release gastrin, and there are parietal cells which are found in the body, fundus. I mean, it's more kind of diffuse, which is called the parietal cells, and they in this context we need to know that they release acid, the hydrochloric acid. Now normally the somatostatin released from the D cell, that delta cell, that somatostatin is it has many functions, and among that one important function is to inhibit the secretion of gastrin from G cells. Again, somatostatin inhibits secretion of gastrin from G cell, but gastrin is known to stimulate secretion of hydrochloric acid from the parietal cells. It's important. Of course, there is how the mechanism of how gastrin stimulate hydrochloric acid secretion from parietal cell, that needs a lot of discussion, but for the purpose of this video, let's say there is some direct action, some indirect action. Like gastrin can act on enterochromaffin cells and then release histamine from there. That histamine can act on parietal cells to release hydrochloric acid or the proton. But yeah, so that is the normal physiology. Now when there is antral-predominant gastritis, what happens is, because there is the gastritis or inflammation going on, it leads to, over time, there is loss of this somatostatin producing T cell or delta cell from this region. Now, if somatostatin is gone, then you can imagine that the inhibitory effect on G cell is gone. Now, what happened is, because of decreased somatostatin, now gastrin release from G cell will be increased, leading to hypergastrinemia. Now, if there is high gastrin level, then it will stimulate the parietal cells, right? These parietal cells to increase the hydrochloric acid secretion. So that is the very, very important mechanism, how antral-predominant gastritis can lead to increased hydrochloric acid secretion in the stomach. Now, in addition to that, this Helicobacter pylori, they produce some cytotoxins there that can inhibit the bicarbonate release in the duodenum. So, because of these two situations where we have increased acid in the stomach and decreased bicarbonate in the duodenum, what happens is, when this high acidic content from the stomach comes to the duodenum, and the duodenum, now there is even no bicarbonate or less bicarbonate, then this highly acidic content can now damage this duodenal mucosa, causing duodenal ulcer. So pay attention to this. The infection is here, right? But the ulcer is happening in the duodenum. So that is the tricky thing here. But if the infection is in the corpus, that is the the corpus-predominant gastritis, then what happens? The parietal cells in the body, they become atrophic. So we lose them. We lost them, and then we know that parietal cells secrete acid, so there is decreased acid, so hypochlorhydria. And the stomach, the acidity in the stomach, it's actually it can kill bacteria, unnecessary bacteria from there. And because now we have lost that acidity, the bacteria, the Helicobacter pylori and some other bacteria, that can overgrow there, and those bacteria will produce different kind of products like cytotoxins, ammonia, and then these products will directly damage the gastric mucosa and causing gastric ulcer. So this is how corpus-predominant gastritis can cause gastric ulcers, whereas antral-predominant gastritis is causing duodenal ulcer. And in fact, in most of the patients who have duodenal ulcer, the cause is actually the antral-predominant gastritis. Okay, so in corpus-predominant gastritis, what happens that another point is, this bacterial overgrowth, those bacteria converts the dietary nitrates into nitrosamine. So nitrosamine is a mutagen, so it acts as a carcinogen, and that's why this nitrosamine can increase the gastric cancer risk. And it can include adenocarcinoma, maltoma, which is a lymphoma. So if we just briefly recap what we said, especially regarding the how Helicobacter pylori causes duodenal ulcer, is as I mentioned, the antrum, when there is this antral region is predominantly affected by the Helicobacter pylori here. So Helicobacter pylori, then this chronic infection would destroy the D cells here, so there will be decreased release of somatostatin, and that's why inhibitory effect from on the G cell is gone, so they will secrete more and more gastrin, and this gastrin can stimulate the parietal cells to increase acid secretion, and this acidic content, when it comes to the duodenum, then it can damage the duodenal mucosa and causing duodenal ulcers, because the stomach epithelium and the stomach mucosa, it is made to sustain or tolerate that acidic environment, acidic content, but duodenum is not. Duodenal mucosa is not prepared for that. So when there is high acidic insult coming into that duodenum, so it can't tolerate that, and there is duodenal ulcer. It can cause duodenal ulcer.